Ready, Derek? Test live, test live. 1-4, test live.
spend some time with us for our Finance Committee and Planning Committee meeting today. I don't believe we have any citizen wish to address to the committee.
No, sir.
We don't. We also, our chief counsel is out, but we still have our legal Rhonda on the phone with us, so if we need anything. We're going to go to item 3, approval for the minutes.
Move approval of the June 23rd minutes.
Second by Reverend Emerson. All in favor?
Aye.
Any all opposed? No question, no comment. We're going to move on to the next item. Number 4 is the finance report from our CFO. Good morning. How are you?
Good morning. So the one thing that I was going to kind of remind everybody about, which I'm sure you're aware, we are having our budget retreat tomorrow here. Starts at 1. Dr. Duncan, Bill, and I have prepared some slides that will be taking you kind of through a macro, federal, state, local, and then we're also going to spend quite a bit of time on specifically how some of those things are impacting the budget for 23. So more to come on that tomorrow, but we'll be ready. So if I can go ahead and start through the financials. So June, from a volume standpoint, you can see that our patient days have remained pretty constant from last month. We are still running slightly below our budget for the year. And down at the bottom right, our length of stay has really kind of lowered over the last 3 months. So there's been some very concerted efforts to watch length of stay, which will also impact that occupancy rate and help with our throughput. From an outpatient standpoint, our emergency department is very close to their budget this month and slightly higher than last month. Our urgent care volumes at the bottom left have returned. You can see there that they are over where we expected them to be this year, but they continue to supplement the emergency department here on the main campus. Our primary and specialty care clinics, primary is right on budget this month, and our specialty, as you can see, remains above budget for this month. For surgeries, our inpatient surgeries are below budget. You can see that our outpatient surgeries have recovered quite a bit the last 4 months. We have had a shift in the types of surgeries that we've had. So although, again, our inpatient surgeries are down for general surgery and orthopedics, you can see on the outpatient slide at the bottom, there was overages in general surgery and orthopedics on an outpatient standpoint. So we have seen that general shift, and our outpatient surgeries, again, remain fairly high. Behavioral health is trending this month, much like it has throughout the year. We're slightly under in our patient days, but the clinic visits, our outpatient services at the top right, remain very high. You can see those are about 26% over for the month and about 17% over year to date. Our PEC, the Behavioral Health Emergency Clinic, is pretty much on target for the year, although it's just slightly above budget. And from the financial side, our patient cash collections, I really wanted to point out some good work that happened. You see the green part of the bar at the lower left. We had, if you remember the CHIRP program, kind of a supplemental funding program from the state, but it is paid on a per claim basis. That program was not approved until about 6 or 7 months within our fiscal year. So we got a huge amount of collections processed through our managed care payers for some of those back payments. So that's a catch up here in June, and you'll also, you should also anticipate a large collection month for July as well on that. So it's kind of a big bolus of cash that came in. It should have been distributed kind of equally in the beginning of the year, but we are starting to see that cash inflow. At the top right, our adjusted patient days are favorable, our adjusted hours FTEs paid per adjusted patient day is favorable. You'll see on a next slide or two, our rate is much higher for labor, but we are favorable from a worked hour standpoint. And then our connection enrollment is trending upward. We had about a 5% increase from 1 month to the next in June, and most of that is coming from new members and some increased efforts to make sure we contact those members who's expiring and making sure that they get re-enrolled. So for June, the medical center, although we had a positive bottom line of $4.8 million, we are behind budget for the month. Most of that is driven by our labor costs, which are significantly higher. You can see under the salary line item and that contract labor line item that as we staff the hospital, those costs have continued to rise and continue to be high. We did have a favorable revenue month. Most of that came from volume on the first line, that $944,000. And then our retail pharmacies, mainly our specialty and central fill, remain very busy this year. Those do have some expenses that offset that $1.8 million overage, but the volumes are flowing through, and they've been fairly consistent throughout the year. Although there's been, again, some savings through purchase service and some other costs, we did end the month behind budget. And if you recall, we have done so. We've really experienced some extremely high salaries since about January. And so when you look at the year-to-date outcome, we are at a $62.7 million operating margin. But we are behind our budget, again, driven by the salary cost. I covered that pretty quick, but are there any questions on the medical center? Yes.
Kind of driving us, and I don't know if I should ask you this or Dr. Duncan. Do we say to other departments or departments throughout to reduce, to address that revenue, that impact on the budget? Or are we still, other departments are still functioning with normal expenditures?
So you will see in some of our discussion tomorrow how we've dealt with new requests for FTEs. There's always new requests every year. We'll be talking about that tomorrow. But I think everyone, as we process any request, whether it's for FTEs, whether it's for purchase service, we are really trying to scrutinize any new expense that we have.
Okay. I asked that because I think back when Trent was city manager and our departments, when the revenue was down or shortfall, he had sent out a memo saying, everybody reduce your spending by such percent to compensate.
I've done that.
All right.
We've actually done that internally too.
That's right.
Department brings it down 4%. As it pertains to workforce, and you'll hear a lot about this tomorrow as we look at the priorities for next year, and really what's going to be in the budget will be a lot around trying to maintain the workforce and the cost that it's going to take to maintain it. We do have really tight controls, and I think the VPs will agree with you, with any new positions especially, and then we really work with them to repurpose what they have with open positions or even with existing positions. So there is a lot of control around an FTE being able to be hired that we'll continue to work through.
I guess I have a different question, because as we wind down, this is probably our third quarter for FY22, and we are now behind by $22 million, I think. What is the outlook for the remaining of FY22? And there are some area here that's remains red for quite some time. Is there any, I guess, changes that we can see that may impact July, August number that can start trending up for us? And my other question around emergency department, it's been yellow and red for a while also as well. And I kind of suspect this may be, we're looking from a financial standpoint, but from the operating standpoint, do we know, do we have the number for left without being seen in urgent care and the other side? And anything that we can change administratively, maybe triage better or improve that area to have people less, left without being seen type thing? And I'm not sure.
So actually, we have Dr. Huggins here, who oversees the ED. There's been a lot of focus on the ED. As you know, we unfortunately, we cannot control the numbers that come in. So it's not a consistent number. So there's days in which, like this week, in which we've been just really churning it out. And it does tax your operations and your ability for throughput and takes a full team. There's a lot of work that's going on across the hospital every day. We have in our, I forget what we call that big room command, Jill may want to join us, but big command center room in which we have the status of the hospital and that the ED is driven through. We do keep track of left without being seen, and that's has come down quite a bit and has pretty much steadied out. So we do not, although that number can be high to your point, if you have, every month down at 6%, if you have it at 6%, even that, given the volume that we have, is a considerable number of individuals who are leaving without being seen. But there is a lot of work that's going on, given the restraints, both space restraints and staff restraints that we work through. Dr. Huggins, I don't know whether you want to add.
Yeah, Mr. Chairman, if I may, we've made this a focus of some of our operations, and I sit on our operations committee, and so we've made some scheduling adjustments to move physicians into a different area to see some of these patients, whereas we had been seeing them with a different workforce of APPs. So we're going to drive the level of the physicians seeing these patients instead, and see if that can make a little bit more of a dent in it. And we've had a decrease somewhat down to the 6% mark that Dr. Duncan had referenced, because it was a tad higher. We've had an extremely large volume this week. We brought some extra people in to see those patients, but it comes with, again, more cost too.
And I would just like to add, I mean, often the focus goes to the emergency department, but it really is a function of our entire hospital throughput. And so when we run out of beds from an inpatient perspective, it backs up in the emergency department. And so it's really that whole cycle and that whole throughput. We are at capacity in our beds most often, or over capacity most often. And so that puts additional challenges in our emergency department and additional stress as well. But to Dr. Huggins' point, Dr. Duncan's point, it's actually something we meet about weekly, left without being seen specifically, not only from an ED operations standpoint, but also from a leadership standpoint, have an action plan associated with that and doing many different things in the emergency department to try to help mitigate that.
I have one question. On your inpatient surgery, do you expect for the outpatient surgery to increase and inpatient surgery to decrease because of the shift in what they are doing?
So we have budgeted for that a little bit different, and I'll be showing you what we are budgeting for 23 tomorrow relative to how we project out. If I recall correctly, our outpatient surgeries look to be a larger increase because of the recovery that we've had. So we really base the last 3 or 4 months of activity to project out what we think is going to happen for the 12 months of 23. So that will be an increase from projected to budget, mainly because of the lower first half of this year. And then we do see continued increases relative to inpatient surgeries, but it's not as great. It's just kind of a continuation of where we are today. Although there are a few new surgeons that are coming on, we've had contract surgeons here in place for some of those surgeries. So not as much of an increase in inpatient, but year over year, you will see an increase in the outpatient surgeries.
Okay.
And Dorothy, to your point, we did shift some of that we were doing here at main campus in more of the outpatient setting. And so some of that increase that you see is because of the procedures that now that can be done more in the outpatient
Yeah,
setting.
that's kind of what I see happening is more of that trend. Okay, all right.
Sharon, what, based on the fact that you said we got a bigger supplement in June than we expected, and you expect some more recovery in July. I mean, if you're looking at the end of the fiscal year right now, knowing that those bumps are coming, what are you estimating us to end up in terms of budget versus actual?
So the cash that you see that I just covered on that bottom left slide, those payments were already accrued on the financials, so you don't see this big windfall. We knew that those were in process, so we anticipated the collections that we received in June and in July.
Okay.
Those are already forecasted in our numbers. So that will not be a windfall of sorts at the end of the year.
So you think this 22 million stands?
Yes, I do. And for the last quarter of this fiscal year, we're not projecting, again, no major changes in the volumes for July, August, and September, as well as any change in the trend of our salary cost. And when we get into the budget for next year, although we have a lot of efforts going around here, I think it would be short-sighted if we did not understand that these inflated salary costs are going to continue for quite a while. And you will see that budgeted for 23. We're not balancing the 23 budget by going in and saying, oh, because we start a new year, we're not gonna incur all of this premium pay in order to staff the hospital. We've actually developed our budget knowing that that is gonna be a slow decline as our workforce recovers, again, from a national standpoint, state, as well as just JPS. And it's going to take time for us to be able to recruit new workforce, get them trained, get them productive here. So part of our strategy that you'll hear about tomorrow is refocusing on that workforce.
Well, throughout the medical community, though.
It is what I would
Let's talk
consider
about that tomorrow, but it
a
is.
major problem.
We actually we have a stroke survey that's going on today and tomorrow, and it was brought up by the surveyors as they're going across the country, that the challenges, especially in your very difficult areas of recruitment such as ED and ICU, where you need these nurses to have experience, ongoing training, to be able to maintain a high-quality stroke program or, congestive heart failure program or acute myocardial infarction program. Hospitals are really struggling with that. And even getting new graduates in, which takes some time to get them trained up and ready, really taxes the system. And so this is going to be a real challenge, and we'll talk about that tomorrow and get your input as to how best to look at this.
We could recruit Dorothy and you back out of retirement,
Do that. You probably.
Well, globally, though, we all have to live with the real world when it comes to what we have the ability to staff. And while on one side, you get people saying, go spend $100 million more right now because we got to have these services right now. Buildings don't equate to services.
That's right.
Buildings still have to have people to service.
That's
We
right.
can't serve the people we have.
Right.
So
You're
there's
right.
more of that talk tomorrow,
There's
too.
more
I'm
of that
guessing.
talk tomorrow, too. No sense of building if we don't have the people.
I have one follow-up question on the ED left without being seen. Is there opportunity, because not all of them require beds, right? And if beds availability. So if they walk out the door, is there an opportunity for us to dissect that and see how many of that is JPS connection, Medicare, Medicaid, or whatever? Are they existing patient? Is there opportunity to have a care manager or someone to talk to them, to set up an appointment for them to go see their primary care instead of just walk out the door without being seen? Because actually, if they can walk out the door, probably more likely they feel good when they're inside the hospital and didn't want to wait. So I just didn't want to waste that opportunity to tie that together so that we can have, because there should be down the road, we have an alert and say, hey, the patient's here, we're acting as a care manager, and they shouldn't be here to begin with. So how do we pull them back to the PCP type thing? So I'm just trying to understand a little bit of the number where it stands, because I don't think bed availability is that big of a challenge if they can't see the doctor yet.
Yeah, this is a conversation that goes on quite a bit, but at the end of the day, we've got to, I believe that triage has to happen at the level of the community, and so that they're not having to come to an ED in order to to come to a place in which is a high level of care, right? And if we can get them into an urgent care or into a medical home before they make the decision to come to the ED. But you're right, I mean, and a lot of that left without being seen, you correct me, Dr. Huggins, is after we've actually done the rapid triage
Right.
front. So
Yeah,
we do get that information.
Yeah, Mr. Chairman, I don't I thought it was directed at someone else, but I can speak to that a little bit because we had a pretty high-level meeting about it on Tuesday. And so we've already pulled the data from our high days of Monday and Tuesday, which are the low acuity people which are coming in and often leaving, so that we can start to make a kind of a different process to route them somewhere else that day, starting at some of the community sites, opening up some places and bringing them there where they can be seen rather than come to the ER and then leave. And all of the patients are seen through triage, and often they're already in a kind of a sub-waiting room where we have people seeing them and ordering things and starting the process of them before they get into the back of the ER. And so I can say that we're really working hard on capturing them, and we do have an element of service recovery when we have some people that say they're leaving, and we have some of the nurse managers that will come out and try to recapture that visit for them. And often they're successful with it, but sometimes people will just get up and walk out the door, and that's hard to fix.
The reason, sorry, I'm dragging this a little bit longer than it should be, but the reason I was looking at kind of trying to understand and reverse engineer the number is that about 15 years ago, when we had responsibility in my past life on revenue cycle and all that stuff, and we saw a lot of challenge in the ED in a smaller town in Oklahoma, like Seminole. I went there at 2 o'clock in the morning, and I brought donuts there. So the staff there at the emergency room, the first thing is that you check in on us. I said, nope, just want to make sure that we appreciate the work that you do at night. So here's donuts and all that stuff, because they're very busy around 1 or 2 o'clock in the morning. After that, then we start having dialogue, and I told the doctor, I said, doctor, do you have a problem we have in the big city? He said, what is it? I said, I know you're doc in the box, you at OU doing residency and all that stuff, so you cover an emergency room type thing. And you have problem with people coming here, asking, basically, at the end of the day, with all the training you have, they just want pain medication or some drug use type thing. And they're going to escalate until you give them something to walk away. Or you have the confidence, or you can deny them so they can walk away, discharge without being ordered, whatever that is. And they tightened up that process because they thought that, as the patient complained, they run all kind of tests and they generate a lot of revenue. But by definition, those are generated with what that not net collection. We only get paid $250 for unless you admit them. At the time, only $250 and $150 for the physician out of a $4,000 or $5,000 bill that we generate for CAT scan or MRI or whatever that is. And once they tighten that up, the whole thing come down. And we appreciate them because they actually stop the patient from denying certain things, because they just sometimes just made up to get more because they go somewhere else because of that. So I've just thrown stuff out that I'm not a medical person, but it did have some impact there.
You remember, Ralph will remember this, 15 years ago now. Mm-hmm. Our left without being seen numbers could have been 12, 15% and even higher at times. And through the work of that initial ED task force, through bringing on IES, from setting new performance indicators, you'll recall, and this was right before Bill Whitman left, we used to get left without being seen indicators in the packet every single month. We had door to balloon time. We had a lot of metrics that we used to get for ED. Those metrics are all still kept. They're just not reported. And I think to some extent maybe seeing those reported again might be helpful. But one thing I can tell you is that was a cathartic experience for JPS and our ED overall process flow, because it completely retooled how the emergency room worked. And the notion that we were just seeing volume because it meant more patients, that's not the case down there. I absolutely know that for a fact, because I made a similar trip to JPS. I didn't bring donuts, but I did make a trip like that. And we've come so far. Back in those days, volume was our biggest enemy, and we didn't have the skill set or the equipment. We didn't even have a decent medical record. in those days. So the numbers were horrible. The numbers have crept back up as a function of volume. There's no doubt about that in staffing. But, I would welcome IES to come back and present to us just how those metrics have progressed over the last few years, because I think they're good.
Right.
I think we've got a very good process, and we've got an excellent team. I think you'll be surprised frankly, how sophisticated the metrics are.
Right. Mm-hmm.
And I think we've got a decent handle on it, but I think it's a good thing to bring back.
Yeah, and whether it's
Let's
here or
take a
whether
look
it's
at it.
quality committee, in which,
Yeah.
process improvement, but there is a lot of resource and attention.
No, I'm with you on that one. I think because we look at financial, we can't put people in the ED. We can only service them, treat them when they're in there. So actually, I think our process is much better, but we look at so much on this one, and we may lose the fact that they're doing a good job, but the financial number may not look good, and we inadvertently think it's not doing a good job. So I'm just trying to figure that out and reverse engineer, see what are we looking at, but not to say that we're doing a whole. I'm not saying that we're not doing a good job. It's just financially, when they walk away, our number is not there. But that doesn't mean we're not doing the right thing, and we need to be very careful when we start looking at it to dissect that a little bit more.
I would like to just add on that as the information that you are collecting, how are we using it to look at what we're doing in our CHCs? Because that should help us identify where we need some urgent hours in the community. If everyone is coming in, if we can identify where they are coming from. So collecting the data and looking at it, and then going a step further to see what we need to put in place so that for the JPS connection and others that are utilizing that, could they stay in their own community? I know we extended hours, but I don't know if those areas know they got extended hours, so they just head right to the ER. So using some of that information and going a little bit farther with how we can work in the communities or make sure that our PCP patients are getting the service they need. That's where I think the concentration should be.
Yeah, what I'm trying to look for is that, there may be a few days gap, but if they left without being seen, and then we turn around and see them back into the medical home, we would be a good source of referral versus the other way that we've seen many, many years ago. So,
Mr. Chairman, I'm going to follow that up, and thanks, Mr. Petty, for the good words. We've got some very good data, and we have a lot of it. We'd be happy to share it in any venue you'd like, whether it's here or PSQG. Two really quick ones for both of you. We have 800 patients that have shown up on Mondays and Tuesdays for dental pain and medication refills year to date. And so that's one of the top ones that we're going to work on, trying to get them seen somewhere else and depopulate the waiting room a little bit. Our stroke survey is going on today, and we went through no less than 50 metrics. But I can tell you personally that over this time, and I've been here for 13 years, 8 or 9 years ago, we were doing quite horribly with stroke, and now we're doing a very good job, and we have some very good data to support that. And that's just one area. So we have lots of data to show you. If you'd like to be more specific on what you'd like, let me know, we'll get it for you.
I'm a little bit stepping over my boundary here, but I think that we would love to see it, but probably not finance, but for the whole board. Yeah.
We can ask for put that on the agenda. That should be routine stuff coming through. Quality on services, so yeah, I can ask them to make sure that that's included on some quality. Okay.
All right, Ms. CFO, I'll return it back to you.
Okay. If there are no other comments on the hospital, I'm going to go ahead and move into a claims activity for the month. Acclaim had quite a few patient encounters above their budget. I think it's a function of a slight decrease of the budget, but it's right at prior month level, about 4.5% above where they expected, and they're right on target year to date for encounters. They're just about 1% under for the 9 months.
Let me ask you a question as we go into the budget retreat tomorrow. I know the number last year were good numbers, but we didn't have, we didn't have, we were in transition with Dr. Becker and all that stuff. So as you see going to next year's budget, do you see a calibration of those numbers so that we can see it better? Because it's probably due to various reasons, maybe set up high, or maybe because COVID have some impact in there and all that stuff. Is it normalized enough for us to see so that we can see truly, is it above or under with the prediction or plan or whatever that is?
So right now, the plan for a claim for physician activity is an increase of about 6% from the current year to 23. So we are seeing an increase in patient touches there.
Mm-hmm. Okay.
Was that your question?
I think, like a better word, I just wanted to make sure that we put a number that's reasonably correct so that we have a baseline to work from. Because all the number is more, are we doing everything the right way? Is it come out? I mean, it's not cut in stone, but at least give us directionally, path to see how healthy our financial and our system is, right?
Yes.
That's all I'm looking for.
All right. And as you look at a claim, again, we've completed 9 months of our fiscal year. This month, they performed about $1 million ahead of their budget. Half of that is due to the strong volumes that we talked about. And there are some open positions as well as transitioning some coverage services that hit that purchase service line item into employed physicians and going back up into the salaries line. So they do have some favorability there as well. And then year to date, you can see they've outperformed their budget by about $9 million, which is the $1 million a month that we've been seeing year to date. When you look at the combined statement, the hospital income along with the investment to a claim, we are right at $40 million operating margin for the first 9 months compared to a budget of about $40.6 million. So we are about $5.5 million behind our budget. Again, the story there, although we have slightly higher volumes for the most part coming through, we are focused on the workforce. Are there any questions for June? Thank you. I think we need approval on the financials.
We have a motion for approval. Second. Any, all in favor? All opposed? Motion passed. Thank you. Moving to item 5, consideration for approval. Item A. Oh, you want to do?
That is item A.
Oh, that was item A. I'm sorry. I have that senior moment now. We're going to change a little bit. We're going to move B and G into the next 2 items so Joy can be up there.
All right. Okay, good morning. So I'm bringing forward for your consideration a products purchase agreement between Secyrus and the Tarrant County Hospital District. This is so that we can procure our flu vaccine for this upcoming flu season. We're able to pre-book and secure that supply. It allows us an additional discounted rate by guaranteeing that volume commitment. And again, this is included in our operational budget for this year.
And this is for all vaccine or just COVID?
This is for flu vaccine.
Flu vaccine, okay. Season already.
Make sure we get yours in there, Trent. It's in there. You and I were talking about that vaccine.
Motion for approval?
Look, second.
Okay. All in favor? Opposed? None.
Everyone gets their flu shot. Okay.
Item G, please.
Another one. All right. Yes, so thank you. This next one is to consider approval of a products purchase and professional services agreement between Siemens and the hospital district. As you know, as part of our MR master plan, this allows us to lock in current pricing for our 2 magnets so that we don't have any fluctuation between now and when those would be delivered, so that we can begin that process of updating our MRI units. So very exciting for this contract. And this is included in our capital budget as well.
Good question. Is this the Siemens, or is this the Siemens side of Cerner Oracle?
You know, DT, I know it's Siemens Healthliners. I'm not sure if there's a differentiation, but I know this is through our GPO Vizient, and so for those Siemens magnets, so I could verify for you, sir.
No, it just, I'll look it up later on. I'm just curious to see if it's part of the other Siemens for, supply equipment type thing versus the software side, the Cerner Oracle takeover.
So when you look in the actual contract, it's inclusive of both the product and the software component. So maybe a both, but that's included in both.
Any question, any comment? Motion for approval? Second. All in favor? Aye. Opposed? None. Thank you.
Mr. Chair, appreciate it.
Item C. Jill.
All right, I have several contracts here today representing the operating room for our patients and our surgeons. The first contract is an approval for a hand implant pricing agreement with Arthrex. This has gone through our RFP process. Estimated annual cost of $225,000, and it is approved in our FY22 budget. This particular contract, there is an estimated possible savings with this supplier of $77,000 per year.
Any question from?
I do have one question on that. What is the projected number of hand surgeries that they could do out of this?
We do about 400 cases per year.
Okay.
So would be included in this opportunity.
Thank you. All right, that was it.
Okay, motion to approve.
Save money. Is that?
Yes, move approval.
That's second.
All in favor?
Aye.
Needed to save money.
Motion passed. Item D, please.
All right, I'm going to go from hands to now knees and hips. This is a pricing agreement with Helmetica Osteonics for orthopedic implants and supplies, specifically for knee and hips. Estimated annual cost is $400,000, and again, approved in our FY22 budget. Implant and supplies for our total knee and hip replacements.
Okay.
Any question? Want to know about the cases, Dorothy?
Oh, I already have that one. Okay. I already have that one. Move approval. I already had that one.
We have a second? Second. All in favor?
Aye.
Opposed? None. Motion passed. Item E, please.
All right, this is a product purchasing agreement with Axogen for nerve graft implants and supplies. This agreement will provide nerve grafts and supplies for our hand reconstructions, breast nerve procedures, oral maxillofacial reconstruction procedures, and trauma procedures. So really covers many different areas. $369,000 for a year and 7.5 month term, which is a kind of an odd term, but we're in the middle of their pricing term period. This also is approved in our FY22 budget.
Okay.
Any question? Otherwise, I'll entertain a motion to approve.
Move approval.
Second by reference. All in favor?
Aye.
Opposed? None. Motion passed. Next item, please.
All right, so this final one, I'm asking for approval for a purchase agreement with Brain Lab. This was awarded through our RFP process. The cost is almost $1.3 million, again, approved in our FY22 capital budget. This purchase will provide 2 OR navigation units, 1 interoperative imaging unit, procedural table equipment, some service support and software updates, as well as set pricing for disposable supplies.
And is this the RFP process also?
It did go through the RFP process. This will be for ENT, neurosurgery, craniomaxillofacial, spine, and trauma procedures.
Okay. Any motion for approval?
My brain.
Move approval.
It's Amanda, second. Motion to approve. All in favor? I'm sorry.
Aye.
None. Motion. Thank you, Jill.
Thank you.
Now we're moving to item H.
Oh, now we're in trouble.
Ms. Barr, how are you?
Good morning, everybody.
Morning.
Thank you for allowing me to present for your consideration a interlocal agreement for the provision of pediatric and adolescent behavioral health services between the Mansfield Independent School District and the Tarrant County Hospital District. Again, this is grant funded through Senate Bill 11 with the Texas Child Mental Health Consortium, and it provides a short-term therapy as well as education and training for teachers, as well as connections to other community resources.
So I do want to shout out to the behavioral health team that presented at the Commissioner's Court yesterday on the TCHAT program. Was well received by Commissioner's Court and stimulated a lot of great conversation. So thank you, Zelia, to you and your team.
So, did you say Mansfield?
Yes, sir, Mansfield.
I noticed in my book it said Millsap. I just wanted to make sure.
The next one is Millsap.
Okay.
Yes, well, actually, yes, I could have done them both
That's fine.
together, I guess, my
Don't worry about
bad.
it.
Thanks for correcting me,
No,
Charlie.
no. Either way, it's Mansfield. One. Great program, and like you said, it's well received.
Should be able to combine those two into.
Okay, and so the second agreement would be for the Millsap Independent School District and the Tarrant County Hospital District to provide short-term pediatric and adolescent behavioral services.
Move approval for both.
All in favor?
It's fun.
Aye.
Opposed? Quick question.
Celia, what other school districts are you missing from the?
I knew you were going to ask me that, Amanda. So,
She's got a chart and everything, so.
yes, I came prepared. So in your area, we are still working with Arlington ISD. I do know that Commissioner Allen is also reaching out to Arlington. I think you have, is it Arlington Academies there? Yeah, we are in the process of signing Arlington Classics Academy, the process of signing an interlocal agreement with them. And then there's still quite a few that initially, when we did this last March, we reached out to all of them, but that was also in the throes of the COVID. And so responses sometimes were slow in coming back, but since the Uvalde school shooting, we have seen a much larger response, and school systems that we contacted before that said, we're okay, are now coming back going, when can you come? Which is great. Also, those of you that might be familiar with the Jordan Elizabeth Harris Foundation, they do the Hope Squads and a lot of outreach, and so they're connected with, I think, 170-something ISDs, and so Tom Harris and I and their new executive director met last week, and Tom is going to work with us to open some other doors that need to be opened. And right now, just for your information, we currently, with what we do have with our contracts, about 175,000 covered kids. And then with the ones pending, that's another 64,000, so well over 200,000 now. growing, and then we're preparing our budget for next year, for the next biennium, and we're anticipating doubling what our current staffing model is, because right now we're only staffed and can for 50%, and so the Texas Child Adolescent Mental Health Consortium has been great. Our partnership with UNT has been amazing, and just one other fact. So remember, I guess it was it the end of last year or the beginning of this year, I gave you all a report out on numbers, and I said I hoped we would be at 1,500 by the end of this year. We're past 1,500 already. Wow. The feedback from the parents and the kids have been amazing, because our hub was the first hub. That must be some construction. Our hub.
Yeah, what are you doing over there, Ray?
That's the window.
I'll go outside.
It's the window, Bill.
Okay.
Bill is the window.
Well, at least we'll have a clean window to look out. There we go.
Ah, they're cleaning the window.
Window cleaner.
Yeah, it'll be over quickly. Everyone remain calm.
Yeah. They're doing their job.
But the good news is, we aren't hearing things because everyone heard it. Yes, absolutely. Yes. So at any rate, we're well past that, but the feedback, so our hub, Tanisha Kennard, who is our executive director over our outpatient services, Dr. Potawiltz, and all of our provider teams, realized that the kids and their families needed to be navigated through whatever was going to happen next, and case managed. And so we actually hired case managers just for the TCHAT program, and it has proved to be a lifesaver because they follow that child and family from start to finish.
Wow. Okay.
And like, for example, a school district, a school referred 2 siblings, ages 5 and 6, that had experienced trauma and were developmentally delayed, and they were referred to us, and we were able to connect with our UNT partners with their neurology program, and the kids are finally, and then in partnership with MHMR for early childhood developmental, and so now those kids are getting all the resources they need to be able to be engaged and moved on.
Great.
I think one additional point is that often the social determinants of health come to light as they're meeting with these families and with these children, and they're actually connecting them to those resources that are needed for that too. So it really is the whole health of the family that they really are beginning to be able to intercede on behalf of. So.
That's why we have the case managers. Thank you for reminding me, Dr. Duncan. But
Oh, go ahead. I just wanted to say that the reason why I asked about the Mansfield Millsap, most people know Millsap's not in Tarrant County.
Right.
I commend this institution. This is an issue, and yes, these are grant funded, and obviously I think we have we have the professionals to handle it. Tom and Elizabeth Harris, dear friends of mine, Jordan Elizabeth, and I support their home squads, been involved in that. But again, this is one of those things where this institution is taking a major step forward to help communities, help our community as we go forward. So I just commend, it's a great program. Again, it's grant funded. It came through a Senate bill, I believe.
Senate Bill 11.
11 did this one, so obviously I've been involved in a little bit along that way. But at the end of the day, I just think it's great what JPS is doing. We're helping kids. There's an issue out there we all know. So anyway, I commend you what you're doing, Zia.
Thank you.
Foundation have an amazing.
Yes.
And I was. It's fantastic the way that they're moving through.
Yeah. Anyway.
So, yeah, great job.
Commend you for what you're doing.
Because it shows that we're getting out in front of.
Yes.
what could be a problem down the road. So,
Absolutely, because the earlier we're able to intervene, the better the outcomes for the children and the family. Kids that don't have access to early intervention for behavioral health issues have a significantly greater chance of dropping out of high school, and then that leads to a whole lifetime of socioeconomic challenges.
yeah, I just might add that just from my pastoral position, in many of the counseling situations, you see it started way back, and now it's a monster now, you know.
You're correct, Reverend.
Yeah. Anyway, great job.
Quick question.
Well,
for-
I would love to take credit, but our team's doing the hard
Great
work.
team.
Quick question for you.
Yes, sir.
Are you tracking the Z code and all that stuff also as well for social determinant of health for that project?
We do. We it's part of our assessment. We were able to use that data to justify changing our budget in order to hire the case managers.
Right. I don't think you can leave yet. We don't have second. And haven't approved it yet. You second?
We already We got it.
We're done.
I thought we had a question before we. Okay.
We typically do, but Amanda went out of order. Voluntary and partial organization.
Thank
I
you.
will out myself on that.
And I just want to tell each of you that we truly appreciate your support because we couldn't do this without it. So thank you very much.
We may be patient someday.
This is true.
The Mendenhall, you next.
Good morning. A couple of points of interest before we get to the contract. Number one, this is a software contract, and one of the things you're going to see from IT perspective, a lot of these software things are going to be transitioning to Will Showalter. But since I helped negotiate this before Will came forward, came to work here, I'm bringing it forward. Secondly, to your question, Mr. Nguyen, Joy and I just collaborated. You had a question about which Siemens group were we talking through, and this is the Siemens Equipment Group.
Okay.
If you remember, there was a Siemens Saurian EMR that at my last hospital where I was a CIO, that was our EMR, that they sold out to Cerner, I think, in 2016. So it's really not, it's really not a relevant EMR any longer. But the software that was approved, that y'all approved just a few minutes ago, is with that Siemens Equipment Group and not the EMR group. Okay. So just wanted to clarify that. Bring forward to you today a renewal of a software package that we've been using for many years, our ServiceNow package. We've added a few new licenses, and we've talked about that in the executive summary for human resources and our incident response management group. We use ServiceNow not just in IT, but we use it across the entire organization for process automation and for keeping track of all the things that we do in a lot of support services groups. So this is for your consideration today. We have budgeted for this increase. We had expected this increase for years 2 and coming up into year 3 of this contract.
Quick question for you. Does it have any, for the ticketing system, does it have any patient information?
No.
Privacy? No.
Zero patient information in it. We keep all patient information in, obviously, the electronic medical record, but we do not certify ServiceNow as a HIPAA software, and so zero patient information goes into it.
Can you give me a little bit example what the use case is for this?
For all of it, or for
just a few?
Yeah. So, and obviously in IT, we take close to 300 calls a day into our service desk, and it automates everything, the process flow through everything through all of IT. So that's one use case that we do. So all of the incidents, all the problems, all the change control, our governance, risk, and compliance. And when we spoke a few weeks ago at governance, talking about IT security, we have the governance, risk, and compliance module within ServiceNow to be able to automate all of our reporting that happens from security. We also do things like all of the processes that happen in communications and community fairs. When someone needs a new logo or they need a new communication to be dropped or something else like that, they use ServiceNow to be able to track and build all their metrics and all their reporting off of that. Textile Services does the same through ServiceNow. So it's not just an IT system. We have lots of people, and now we're going to be using that in HR to be able to formulate all of the processes when people have requests for HR so that they can build their reporting and metrics. Get off of spreadsheets and pieces of paper to keep track of those requests.
I just want to make sure, because like point of sales and all that stuff may have some.
Yeah, we do not actually do any CRM, point of sale, any PHI or PII, anything like that into ServiceNow.
So our clinical team or administration team can't circumvent some of the data for collection or anything like that?
In fact, we don't even, the only data that we push to ServiceNow, because there's a clean line of demarcation between our patient data and ServiceNow, the only data that we push is like Active Directory data, so usernames and passwords. And in fact, that data is intermediated through a third party, so that there's no question ServiceNow cannot really see our data one way or another.
Thank you. May I entertain motion for approval?
Move approval.
Thank you.
Second.
Second. All in favor?
Aye.
Opposed? Motion passed. Thank you, David. The next item is going to be from Derek. Good morning, Derek. How are you? Before you get started, after this meeting, the next one, we're going to change the process a little bit so that, if you don't mind, we're going to put, we already asked to have a JPS person for approval because you're not a JPS employee, so we're going to change that so that you'll be helping whoever's sitting there with the subject matter expertise type thing. So please, go ahead.
Yeah, thank you. I'm filling in for Adam. Normally he would be here, but he's on PTO, so thank you. Got for your consideration 3 contracts for your approval that are important to the bond program. The first one is the agreement between Beck Potiri joint venture, and they're going to do the design build for the new parking garage. So again, it's critical on the critical path, but this is for the new 2,800 stall parking garage that will be adjacent to the new medical office building.
Any question on the parking garage?
What is so complicated about this? Parking garage.
It should not take that long. Our schedule is really more like 16 months.
The final completion date in the contract is February 28, 2025. It just seems like it seems 8 to 9 months too long.
It is. Probably because it's also in conjunction with the MOB project, so that may be the reason why it's got a longer duration on it.
Can we take, I don't want to hold it up, but can we take a look at that and reverse engineer the parking garage piece of this and not give them an extra 8 to 9 months to get this thing constructed? Because this literally holds up everything, right? Until this is finished, nothing else can happen down here.
Right.
So if we could take another look at that, 24 months is a long time. 29 months is extraordinary amount of time for a parking garage. So if we could just take a look at it, I'd appreciate that.
We will.
You want to table, or you want to come back and let us know how they can optimize it?
That'd be great.
Okay.
That'd be great.
Right.
So we're going to table this one?
No, I think
No,
we're
my
going
intent wasn't to table, it was just simply to.
we're going to try to approve it, and then he'll go back and try to optimize it.
Oh, okay. All right.
Optimization.
So I'll make a motion to approve with that caveat.
Yes, sir.
Okay. All right.
All in favor?
Aye.
Opposed? Motion passed. Next one, please. Go ahead. The next one.
So the second contract is for an amendment to the contract for Beck Architects. They're the architect that's working on the PEC project. So this is an increase of scope. The original scope was put together back in April of 2021. Since that time, we've had some updates to the master plan where the PEC project will be here for a little bit longer duration until we get the new behavioral health hospital built. So it's a temporary location for the PEC, but it's a permanent building. The building will have use after this, but the increase is for the increased number of KPUs, the number of care stations, also just the enhancements that are needed for that longer duration. We've also discovered that there's some unforeseen conditions that when we did the SU analysis, which is the underground utility study, that there's an easement there. So there's a couple of things that have come up that were not foreseen in the original contract. So that's what this is for, is to increase their contract due to those reasons.
Any question, comment before we entertain motion for approval?
Second.
Second. All in favor? Opposed? No? None? Motion passed. Next item, M, please.
All right. So the next one is for Corrigan Architect, and we want to have them under contract for all of our architectural standards. So they'll be putting together the standard spec for all the projects, so there's consistency. In addition to that, they'll be developing the design standard that will be a part of JPS. So there's a lot of organizations, hospitals that have standard specifications, and this is what this will develop. Currently, JPS doesn't have those standards, but this will apply to the bond program and even further so that those projects are consistent across the board.
Any question, comment?
But these design standards, ideally, are not only going to apply to the elements of the bond program, they're going to be a new template standard for JPS facilities from now on, right? Because when we talked about this in the first place, it was we need to take advantage of the fact that we're spending all this money on the bond program and apply additional elevated standards to all JPS new construction projects. So we're going to have capital projects that come about without necessarily being under the umbrella of the bond program. The hope here was that these design standards become specific to JPS, and at least for the foreseeable future, we have a design template that we can apply to all of our capital projects and all of our master plan projects to be consistent with this. That's still the case?
Yes, that's
okay.
true.
You good with that?
No, totally agree. I guess the question would be whether we've ever had any
I don't think we did.
templates. And if we did we take those into consideration when putting this together, right? So that there isn't the mismatch. But you make a good point. This should be moving forward.
We have a motion for approval.
Okay, second.
All in favor?
Aye.
Any opposed? Motion passed. Thank you, Derek.
So I got a question.
Yes, sir.
Now, we didn't put the cart before the horse, did we? Because the signs are up. So did we put the signs up just knowing we were going to get it and approve it today?
Yes, it was wishful. Yes. Good question.
They had another sign that said, except for Reverend Emerson's vote.
At this point, since it's a joint planning meeting, I'm going to turn the next section over to Chairman Petty.
Thank you, sir. So in terms of the Executive Steering Committee update, our last meeting was productive. We were able to begin to now apply the expectations of operating cost to the capital measures that we're considering. And those were obviously important and eye-opening for the judge and Commissioner Brooks, who were both in attendance. We're going to continue Price Waterhouse work to making sure that we're tracking operating costs with capital costs on every aspect of the bond program moving forward. And it underscores what Chairwoman DuBose has said now for about 6 months, which is until you have the people, you can't really build a building, right? So this has been a central focus of this committee, is to make sure that we're tracking design costs and capital costs but also measuring operating costs so that we know what's ahead of us. So other than that, I think we're on track. All the items that were on the agenda today have been through the steering committee. All those have been approved. So with that, Derek, did I miss anything? Okay, then we would need to bring Angie up for our capital project update. Hi, Angie.
So, as Angie's come, the article came out that this was that same article.
That article was, how do I put this? Not as informative as maybe I would have liked it to have been. And then,
because I know the article came out right at the same time the science went up. And I'm saying, hey,
yeah, it's always interesting when the press asks everybody except the people that know what's going on.
right.
Yeah.
Okay, we're
Angie,
ready?
we're ready.
Hi. Thank you all for allowing me to present this little report on our capital construction that's routine capital, so non-bond related. Our first one, if you've driven down Main Street, JPUC 1400, the building closest south, you've seen all that scaffolding. We're repairing that brick parapet above, very top of the building. I know you've seen it if you've been down Main Street. We talked about it last quarter. That is finishing up. The scaffolding is coming down right now, looking a lot better. It looks great. So that's in punch out and should be completely done within 2 weeks. So that's good news. We're glad to get that off the list and keep everybody safe. The second one.
Stop handing out the stainless steel umbrellas.
Exactly. Yeah, well, I'm glad we got that repaired as quickly as we did. JPUC 1350, so that's the building to the north. That retaining wall repair, if you looked at the pictures, there had just been a lot of water intrusion under that building that washed out everything under there. So we've got a grade beam poured. They're doing a really good job. We're doing a little bit of civil work, some excavation out there, and creative landscaping to keep the water from coming back in and to redirect the water into the storm drain. So that's good there. That one should complete at the end of September. We're trying to get these done by the end of the fiscal year if we can. Both of these projects coming in well under budget, so I know Sharon's happy about that. The Hemphill building demo, if you've been on the corner of Hemphill and Allen, the ever-popular Metro West building is down. The picture's not up. I wish it was, because when I selected the picture to go up there, oh, thank you. I did this specifically. If you look at the picture on the left, you can see the building in the background. The picture on the right, it's gone. But the picture on the left, y'all look, there's water in the street. That was a big rain. And I thought, so there is hope. There is hope that rain is going to come. But that is, it's coming. We're hoping to complete that the middle of September. I will tell you, we've had one little hiccup there. We found a fuel storage tank that was completely hidden and unforeseen. It's about a 4x4 tank, so they had to contain that, get it out. We're still waiting for the cost back, but we do have contingency in that project. But oddly, nobody has any earthly idea why that was under there. That was an old nursing home, so no idea, but we're taking care of business there. But we'll be completed middle of September on that one, and that will get us a net add of 119 new parking places for a total of 366 in that lot when we're completely completed. Any questions? No?
Brandy?
No, thank y'all so much. Appreciate it.
We appreciate it very much.
Looking good.
And Derek, can you give us an update on the Southwest Medical Home?
So the Southwest Medical Home is moving along very well. We've got our Byrne is the design build firm with Sterling Barnett Little and Postel. We're in schematic design right now, and it's moving really at a very fast pace. We've got even exterior renderings that are being developed now that we plan to bring to the next executive steering to give you a sense and idea of what that's going to look like. Pertaining to the property, we are have agreed upon purchase agreement, and I just wanted to briefly go through a few things related to that, to the due diligence work that's being currently done so that we can make sure that the property meets all of our requirements. But we've got survey that we're working on. Tignall & Perkins is the civil engineering firm that's working on that. And so the work that they're doing is on a topo survey as well as an Alta title survey. The Alta title survey will discover if there's any right-of-way issues or any easements, anything like that encumbers the property. That'll be discovered. This process takes a couple of weeks to get through. Tignall & Perkins is also doing a SU, so that's the subsurface underground engineering to make sure it's like what we just talked about on the PEC project that discovered some underground type piping or anything like that. So Tignall & Perkins is doing the SU. Also, we're doing zoning research. It's under the PD 655. So we're making sure that, and there's not a problem with that, but that's a planned development. So making sure that the building meets all those planned development requirements. Again, most of that work is all being done by Tignall & Perkins. We also have currently working on Geotech, and Geotech is where we go in and we do borings at the site to determine what that soil condition is underneath the surface so that we know what the structural engineers will need to design to. We've got a preliminary report back on that. We do have some clay that tends to shift, so that'll be incorporated into the design, and that's really important that we know what that is. Including with that is an environmental study, so that's a phase one of the environmental. If nothing shows up for any environmental concerns, we're good. If there is something that shows up, then we'll do a phase two of that environmental study to make sure that there's nothing underground that we need to be aware of, like a storage tank like at Hemphill. So make sure nothing like that shows up. So that work is currently also being done. Alliance is our geotech that's currently doing that work. We will be required to do a plat of that property. The plat will be done by Tignall & Perkins. It's several steps to go through. There's a lot of information that goes into that plat, including traffic information, traffic study, as well as drainage. So they will be working in conjunction with the engineer that's designing the building. Tignall & Perkins is our civil that's doing all the survey work, and they're going to work on all of our projects, but we also have a design civil that will be feeding information at Tignall & Perkins. So all of that information and a title search is also being done by the title company right now. We should get that back next week. And then once we get all of our research done and the property's good to go, then we will then be able to move forward with the final closing of the property.
Isn't that scheduled for when?
The final closing mid-September.
On the platting, after that, once they look at to do the platting, will that have to go before city?
Yes, sir. Yes, it's a 90-day process for a plat. So we also, I'm going to mention that we have a pre-development conference with the city that's scheduled for August the 11th of the overall project. A benefit that we have on our team is someone that has worked for the city and has been in that development department that processes the plat. So we're going to be running a parallel track with the plat process as well as the building permit, because typically you can't get a building permit without a plat. So we're running that parallel path and just staying in close communications with the city on that.
Yeah, I asked that because I know how slow they can be sometimes.
Yes, sir.
That's what I was.
So Derek, since we have a PD we're opening up, when we have DRC, we need to make sure that if there's the opportunity to do PD amendments to make this thing consistent with zoning, that we track that with the plat process too.
Okay.
Because they could run the PD amendment along with the plat on the same agenda, one following the other. Let's not get caught in a situation where we get stuck in zoning on a PD amendment for 3 or 4 months while the plat's then being held up.
Yes, sir.
So all that due diligence, and you said that TNP is handling all that?
They're handling the plating process.
Okay. Who's
And they're-
handling the zoning process?
TNP as well.
They are?
Yes.
Okay. So let's stay on top of that, if you don't
Okay.
mind, and keep us in the loop, because that's the one thing that could delay this thing even further. And from a closing stand, is our closing conditioned on zoning approval?
Yes.
So we could be looking at a delay in closing if
Potentially.
we've got a problem with the PD zoning amendment, right?
Yes.
Good. So we're going to have to keep the pedal to the metal on this thing.
You can run it concurrent, though. We did that.
You can, and we
Yeah,
should.
we run our buildings that
We
way.
just got to make sure we've done all that due diligence.
My other question is, on the design, is the design team doing any meetings with medical home staff now to talk about pluses and minuses of facilities before they actually bring a design forward?
Yes, we've been working closely with Joy, with Zelia, and there's other team members that have also been involved with that. Dr. Becker had an opportunity to review that this past week as well. So we've got staff that's involved in the careful planning of the building. Yes.
Yeah.
Okay, any questions for Derek on medical home update? All right, Derek, if you'll then start walking us through the other matters requiring approval of the committee. The first is the hospital D&T and the towers RFQ.
Yes. So the next three, A, B, and C, those are RFQs that we would like to start in the process of getting solicitations. To be clear, the hospital, we're referring to the new hospital tower. D&T is diagnostic and treatment, which is a component of the new tower. The purpose for that is a key part of on the timeline is the North Pavilion expansion. That's really the connector. So we need to have the architect and the engineers that are involved in that connection with the new hospital on board so that they're coordinating. So we don't do something in that connector that could conflict potentially with the design and how it connects to the new hospital. So that's the reason why we want to go ahead and get them on board early.
And that's limited, that towers element is limited right now to the pavilion expansion component, not to design specs related to the new bed tower, right?
The North Pavilion expansion is only that.
Okay.
This would bring on the AE firm that would do the tower.
But they wouldn't be released to do begin the tower actual work until we have the pavilion expansion piece of this thing finished, right?
Right.
Okay. We didn't take action on this? I guess we do.
Yes.
Okay, so you've heard the presentation for the diagnostic and treatment as well as the towers RFQ. We have a motion to approve. Move from Ralph, second from Dorothy. Any question or discussion? All in favor say aye. Aye. All opposed, same sign. That motion carries. And art consultant RFQ, Derek?
Yes, this is for the art consultant to be involved in all of the projects so that we'd have the consistency. But the art is an important part. It carries an important role, and there's sometimes there can be design components of the art that goes with the furniture. So there are consultants that we typically bring on board that focus just on the art piece. So that's what this consultant would be.
So we need to release the RFQ for art. We have a motion. Ralph, second from Dorothy. Any question or discussion? All in favor say aye. Aye. All opposed, same sign. That motion carries. And activation move consultant.
So activation move consultant is when the building is ready to be opened, and we've got a lot of equipment moving into that. So you have a lot of staging, you have a lot of warehouse activity. So that's what this consultant does, and they QR code everything. So that's what we need to have so that we have that ready for the medical home as well as the PEC, and then they'll do the rest of the projects in the bond program as well.
Okay, questions? If not, need a motion. Charlie?
Yeah, that's fine.
Motion by Charlie, second. Dorothy?
Got to keep up with stuff.
Question or discussion? All in favor, say aye.
Aye.
All opposed, same sign. That motion carries. A waterproofing consultant, something we don't need in North Texas anymore.
Right now. So these are ones that have already been through the process. These are ones that do not need to go they're based on the planning committee that does that selection here at JPS. So waterproofing is obviously to make sure that we've got buildings that are waterproof and sound, and you want to have a third party. You don't want to rely just on the contractor for that. So they come in and do testing to make sure that the windows and the building doesn't leak. So that's what this consultant's for.
Can we recommend all three of those at one time? Or they have to be separated? Where's Rhonda?
He's on the phone.
Hi, Rhonda. Didn't even see you sitting beside me. Can we take the recommendation for waterproofing and commissioning and wayfinding all at one motion?
Hi, so sorry, there was a delay because I'm having to watch you on YouTube to be able to hear you because the phone is so quiet. But yes, I think you can go ahead and take those in one if you like.
Awesome. Thank you very much. Appreciate it, Rhonda. So commissioning consultant and wayfinding, Derek?
Yes, so I'm being specific here that we're asking for specific firms that have already been selected. So the Curtain Wall Design is the company for the waterproofing. AEI is the firm for the commissioning consultant, and Focus EGD is for wayfinding.
And these are all JPS decisions. These don't get carried over to Commissioner's Court, right?
Right.
Okay, so we've heard the recommendation. We can take all these at once according to Rhonda. We have a motion?
Move approval.
All right, Dorothy, second by Ralph. Any question or discussion? All in favor say aye. Aye. All opposed, same sign. That motion carries. Thank you very much, Derek. We appreciate it. Mr. Chairman, turn it back over to you.
The executive session according to Chapter 551 of the Texas Government Code. Thank you, everybody.